All right, let's unpack this. We often talk about the heart, its incredible rhythm, its tireless work. But have you ever truly paused to consider what an engineering marvel it is?
It really is.
At its core, it's a pump, right? Relentlessly pushing blood to every cell in your body, delivering that vital oxygen. Today, we're not just glancing at it. We're taking a deep, detailed dive into understanding precisely how this pump functions. The intricate dance of forces and volumes that keeps us alive.
Exactly.
And perhaps even more critically for your journey as students, we'll explore what happens when this marvel falters, leading to the complex syndrome we call heart failure. This isn't merely fascinating material, it's absolutely foundational. This understanding is crucial for your upcoming medical exams, yes, but more importantly, for truly grasping patient assessment and management in the clinic. So let's get right into the heart of the matter.
Indeed. And to navigate this essential topic, we've compiled a comprehensive stack of sources, a series of detailed lectures covering cardiac physiology, pathophysiology, and pharmacology. Our mission here is really to distill this complex, often dense information into truly actionable knowledge for you.
Right.
We're going to connect the intricate cellular mechanisms we discuss to the clinical presentations you'll encounter in patients, and then, most crucially, to the therapeutic principles you'll apply to manage these conditions. What's truly fascinating here, and what we really want you to grasp, is just how interconnected all these systems are. Understanding these links, from the single ion channel in a cardiomyocyte right up to the systemic effects on the entire body, it's the bedrock of becoming an effective, compassionate clinician.
That's a perfect framing. So let's begin with the heart's fundamental job, ensuring adequate blood flow, what we call cardiac output, right, to deliver oxygen and nutrients to all the tissues. You might recall our old friend Ohm's law, which we can analogously apply to circulation. Cardiac output, or blood flow, equals the pressure gradient. That's arterial pressure minus atrial pressure divided by the resistance. But even more central to our discussion today, cardiac output is also equal to the amount of blood ejected with each beat, the stroke volume, multiplied by the heart rate. Our primary focus for this initial segment will be on the determinants of that critical component, stroke volume. Because if you understand what controls each beat, you're well on your way to understanding both health and disease.
Precisely. Stroke volume is really the central pillar here. It's the quantity of blood the ventricle expels with each contraction. To truly grasp both normal function and the various states of cardiac dysfunction, we need to break it down into its 4 key determinants. We'll be covering cardiac preload, which elegantly ties into the Frank-Starling effects, contractility, which speaks to the intrinsic strength of the heart muscle, cardiac afterload, representing the resistance the heart has to overcome to eject blood, and finally, heart rate itself and its crucial interplay with stroke volume.
Okay.
Integrating these factors is not just about memorizing equations. It's about understanding the dynamic interplay that dictates the heart's performance moment to moment.
Let's jump right into the first determinant then. Cardiac preload and the famous Frank-Starling relationship. This is a fundamental concept, one I'm sure you've revisited many times in your studies. But let's try to really solidify it by connecting it back to the length-tension relationship in skeletal muscle and seeing how it applies specifically to the heart. What does this intrinsic mechanism really tell us about the heart's remarkable adaptability?
Yeah, the Frank-Starling mechanism, often simply called the Frank-Starling law, describes an intrinsic property unique to cardiac muscle. Imagine the heart as a remarkably adaptive balloon. As the end diastolic volume increases, meaning the ventricle fills with more blood just before it contracts, stretching the cardiac muscle fibers, specifically the actin and myosin filaments, their physical alignment within the sarcomere actually improves.
Okay. Better alignment.
Exactly. This better alignment allows for a more optimal formation of cross bridges between the actin and myosin. The result: a more forceful contraction and, crucially, an increased stroke volume. What's truly remarkable here is that this occurs without any additional external nervous or hormonal stimulation. It's the heart's innate ability to adjust its output to its input.
Like a rubber band.
Precisely. Think of it like stretching a rubber band. The more you stretch it up to a physiological limit, the more forcefully it recoils when released. On the classic Frank-Starling curve, which plots stroke volume on the y-axis against end diastolic volume or pressure on the x-axis, an increased filling volume moves you along an up the curve, yielding a higher stroke volume.
Right.
If the normal relationship is depicted by a black line, then increased filling effectively pushes you further along that black line to a higher stroke volume, something we might illustrate with a green marker for a more robust fill. Conversely, decreased filling means you move down that same curve to a lower stroke volume, perhaps marked in red. This immediate intrinsic adjustment is the heart's first line of defense against changes in blood return. And here's a profound insight for you, thinking clinically. This very act of the heart stretching and trying to pump harder, which is initially compensatory, is also the mechanism that can eventually contribute to its exhaustion in heart failure. It makes early heart failure deceptively silent to the patient sometimes.
So the more the heart stretches, the more forcefully it pumps, an intrinsic capability. But what factors in the body actually influence that filling volume, that preload in the first place? How does the body control how much blood is available to fill this adaptable pump?
Yeah, that's key. There are several critical factors that determine how much blood returns to the heart to fill it. Firstly, venous return is paramount. Consider postural changes. When you stand up, gravity causes blood to pool in your lower extremities, decreasing venous return to the heart and thus decreasing preload.
Right, you feel that sometimes.
Exactly. Conversely, lying down minimizes these gravitational effects, allowing more blood to return and increasing filling. Intrathoracic pressure also significantly impacts it. If you increase intrathoracic pressure, like during a Valsalva maneuver, bearing...
Holding your breath and pushing.
Right. It compresses the vena cava and decreases venous return, thereby reducing preload. Conversely, the skeletal muscle pump, powerfully activated during exercise, compresses deep veins in the legs, propelling blood back towards the heart and dramatically increasing venous return and filling.
Okay, so movement helps.
Definitely. Beyond that, the state of the veins themselves, which act as the body's capacitance vessels, is crucial. If veins constrict, they push more blood centrally to the heart, increasing filling. If they dilate, they can pool a significant volume of blood, reducing filling. Similarly, while less direct, the state of the arterioles plays a role. If they constrict, they increase systemic vascular resistance, making it harder for blood to flow downstream, which can eventually reduce venous return. If they dilate, they reduce resistance, improving forward flow, which can then contribute to increased venous return over time, filling the venous side.
Fascinating how interconnected these systems are, regulating the initial stretch. What about the overall blood volume? Does that play a direct role?
Absolutely. Blood volume itself is a direct and obvious determinant. An increased overall blood volume directly correlates with increased cardiac filling. Simple as that. On the flip side, diastolic dysfunction is a major factor that restricts cardiac filling. This isn't about blood volume per se, but about the heart's inability to adequately relax and expand.
So the heart muscle itself is stiff.
Exactly. It could be due to a stiff left ventricle from chronic hypertrophy, or external compression from fluid accumulating in the pericardial space, or even an inherent impairment in the relaxation process of the myocardium. In any of these scenarios, the ventricles simply cannot accommodate adequate filling, inevitably leading to a decreased stroke volume. And critically, an excessively high heart rate can profoundly reduce the time available for ventricular filling. If the heart beats too fast, there simply isn't enough time during diastole for the chambers to adequately fill.
Makes sense. Not enough time between beats.
Right, which directly reduces end diastolic volume and thus stroke volume. Lastly, if the volume ejected by the heart in a prior beat is decreased, say due to a transient weakness, more blood is left behind in the ventricle. This effectively increases the subsequent filling volume, which, by the Frank-Starling mechanism, can lead to an increased subsequent stroke volume as a compensatory effect. It's a remarkable compensatory dance.
Wow.
So you can see how all these factors subtly and not so subtly interact to determine the preload, influencing the heart's starting line for each contraction.
That paints a very clear picture of preload. Now, let's shift our focus from the passive mechanical stretch of preload to the heart's intrinsic ability to truly squeeze harder. This is where it gets really interesting, I think. How does the heart truly increase its pumping strength, its contractility, independent of how much it's filled? This speaks to the heart's raw power, doesn't it?
Exactly. This is where we delve into contractility, also known as inotropy. We define it as an increase in stroke volume for a given filling volume. On our Frank Starling curve, an increase in contractility isn't just moving along the curve, it's a distinct upward shift of the entire curve.
Ah, the whole curve moves up.
Precisely. So for the same end diastolic volume, an increase in contractility represented by a new curve positioned above the normal one, maybe a red line above the black, means a higher stroke volume. Conversely, a decrease in contractility, shown as a curve shifted downward, perhaps a blue line below, means a lower stroke volume for that same filling volume. It's like the heart suddenly becomes a more efficient, powerful pump, unrelated to how much it's stretched.
So what specific factors cause the heart to contract more forcefully or less so, independent of its preload? What turns up the power, so to speak?
A key physiological driver for increasing contractility is sympathetic nervous system, SNS activation. This is your body's fight or flight response kicking in, releasing noradrenaline, which acts directly on the heart.
Adrenaline rush.
Essentially, yes. We can also directly administer beta-adrenergic receptor agonists, drugs that mimic the effects of noradrenaline, like dobutamine. Another powerful way to boost contractility is by increasing intracellular cyclic AMP. This can be achieved through the use of phosphodiesterase inhibitors, drugs like caffeine, interestingly, or medically, milrinone or amrinone, which prevent the natural breakdown of camirone, thereby prolonging its effects.
So my morning coffee is technically helping my heart contract.
In a very, very small way, theoretically, yes. Don't rely on it for heart failure, though.
Noted.
Furthermore, stimulating long-acting calcium channels, specifically L-type calcium channels, increases calcium entry into the cell, directly enhancing contraction. And finally, inhibiting the Na plus K plus AT pace pump leads to increased Na plus He2 plus exchange, which surprisingly increases intracellular calcium and contractility, a mechanism we'll definitely unpack when we talk about digitalis later.
Okay. And what decreases contractility?
On the flip side, contractility can be significantly decreased by conditions like hypoxia, insufficient oxygen supply to the heart muscle, widespread cell death, as you'd seen a large myocardial infarction, pharmacological depressants like beta-adrenergic receptor blockers, which intentionally block the effects of noradrenaline, and activation of adenosine type 1 receptors, which mediate an inhibitory effect on contractility.
Let's really unpack those cellular mechanisms, because that's where the magic happens, right? And it's absolutely crucial for you, our listeners, to understand how these drugs and physiological processes truly work at the fundamental molecular level for your exams and practice.
Absolutely. Let's trace the signaling cascade from sympathetic stimulation down to muscle contraction. When the sympathetic nervous system activates, noradrenaline, or norepinephrine, is released and binds to beta-1 adrenergic receptors on the cardiac muscle cell membrane. This binding activates stimulatory G proteins, or G's proteins. In the presence of oxygen and ATP, which is important, this activation leads to a significant increase in the intracellular formation of cyclic AMP, CMMP, a crucial second messenger.
Okay, so noradrenaline triggers more CAMP. What does CAMP actually do?
This increase in CAMP has widespread and profound effects on cardiac function. It directly increases contractility, inotropy, making the heart pump more forcefully. It also increases heart rate, chronotropy, speeding up the beat. Furthermore, it enhances conduction velocity, dromotropy, allowing electrical signals to propagate more rapidly through the heart. And quite importantly, it improves relaxation, lusotropy.
Relaxation, too. That seems important for filling.
Critically important. Better relaxation is crucial for efficient and rapid ventricular filling during diastole, preventing a stiff, poorly filling heart. So CMP is a true multitasker in the cardiac cell. Now, naturally, there are enzymes called phosphodiesterases that break down CMP, ensuring these effects are regulated. But if we inhibit these enzymes with phosphodiesterase inhibitors, like milrinone or caffeine—
Back to coffee again.
Haha, yes. We effectively increase the intracellular concentration of CAMP. This then enhances all those critical functions: contractility, heart rate, conduction, and relaxation.
And how did this increased CAMP specifically translate into a stronger squeeze and more powerful contraction at the very cellular level? You mentioned calcium before. It sounds like a calcium dance.
It's entirely a calcium dance. CCAMP enhances the opening of long-acting calcium channels, L-type calcium channels, embedded in the cell membrane. This allows a greater influx of extracellular calcium to enter the cardiomyocyte. This initial influx of calcium, often referred to as a calcium trigger, then binds to ryanodine receptors, RYR, located on the sarcoplasmic reticulum, SR, which is the cell's internal calcium store.
Okay, the SR.
This binding triggers a much larger explosive release of calcium from the SR into the intracellular space. This massive surge of intracellular calcium is the key. It then binds to specific regulatory proteins. troponin C and calmodulin. This binding is what ultimately removes the inhibitory action on the actin-myosin filaments, allowing for actin-myosin cross-bridge formation.
That's the actual contraction mechanism.
That's the fundamental molecular basis of muscle contraction. The more calcium available to bind to troponin C and calmodulin, the more cross-bridges form, and the stronger the contraction. And for relaxation to occur, CMP also plays a vital role, demonstrating its effect on lusitropy. It binds to a protein called phospholamban, which then activates the SRCA2 plus ATPase pumps, circuit pumps.
Pumps to get the calcium back.
Exactly. These pumps actively transport calcium back from the intracellular space into the sarcoplasmic reticulum. This removal of calcium from the cytosol causes the calcium to dissociate from troponin C and calmodulin, breaking the cross bridges and allowing the muscle to relax. So CMP beautifully orchestrates both the enhancement of calcium entry for contraction and its efficient reuptake for relaxation, ensuring a robust yet rapid and efficient contraction relaxation cycle.
That's a truly intricate mechanism. You also mentioned digitalis and its effect on contractility, stating it inhibits the Na plus K plus ATPase pump. How does inhibiting that pump lead to increased contraction? That seems a bit indirect, almost counterintuitive, far upstream from the calcium dance.
It is a clever, indirect mechanism involving ion exchangers, and it's a great example of how a cascade of events can lead to a specific clinical effect. Digitalis, a powerful pharmacological agent derived from the foxglove plant, directly inhibits the NAN plus K plus ATPase pump embedded in the cardiac cell membrane.
Okay, the sodium-potassium pump.
Right. Normally, this pump actively pumps 3 sodium ions out of the cell for every 2 potassium ions it pumps into the cell, thereby maintaining a low intracellular sodium concentration. When digitalis inhibits this pump, sodium is prevented from being extruded from the cell, leading to a gradual increase in intracellular sodium concentration.
Okay, so sodium builds up inside. Now what?
Now, the cell also has another important protein called the NAM plus CA2 plus exchanger. This exchanger typically uses the steep sodium gradient, high sodium outside, low sodium inside, to remove calcium from the cell. It generally pumps 3 sodium ions into the cell in exchange for 1 calcium ion out of the cell. However, when intracellular sodium becomes high due to the inhibited Na plus K plus ATPase, this driving gradient for the Na plus CA2 plus exchanger is significantly weakened or even reversed.
The gradient flips.
Or at least weakens considerably. With less sodium moving in, the exchanger becomes less efficient at pumping calcium out, or may even start working in reverse, bringing calcium into the cell to exchange for sodium leaving. This increased accumulation of calcium within the cell then binds to troponin C and calmodulin, ultimately leading to increased actin-myosin cross-bridge formation and thus increased contractility.
Wow.
So digitalis boosts contractility not by directly affecting calcium channels, but by subtly altering the cellular sodium gradient, which then impacts calcium handling. It's quite elegant, really.
Fascinating how a seemingly indirect chain reaction of ion movements can lead to such a profound effect, a stronger heartbeat. Now, let's pivot to our third determinant, cardiac afterload. This is the resistance the heart must pump against, much like trying to push open a heavy resistant door versus a light, freely swinging one. What are the core principles behind afterload, and how does it influence the heart's performance?
Afterload fundamentally is the load or tension that the ventricular muscle must develop during contraction to eject blood. When afterload increases for a given filling volume, the stroke volume typically decreases. On our Frank-Starling curve, this is seen not as movement along the curve, but as a distinct downward shift of the entire curve.
So the curve shifts down this time.
Exactly. For the same end diastolic volume, an increased afterload means a lower stroke volume, which we could illustrate with a blue line shifted below the normal black line. This tells us that the heart has to work much harder to achieve the same output, or it achieves less output for the same effort. To understand afterload more deeply, we often turn to the law of Laplace. This fundamental law of physics, applied to a sphere like the ventricle, states that wall tension, which is our clinical representation of afterload, is equal to pressure times radius divided by 2 times wall thickness.
Pressure times radius over 2 times wall thickness. Okay.
What this equation powerfully tells us is that if the wall tension or wall stress is increased, meaning the heart has to generate more force per unit of muscle to overcome the resistance, the heart has to work significantly harder. This, in turn, disproportionately increases its oxygen demand. And ultimately, increased oxygen demand with insufficient supply can severely compromise the systolic function of the heart, leading to a downward spiral.
So what specific factors, looking through the lens of the law of Laplace, cause this afterload to increase, or conversely to decrease?
From the law of Laplace, we can deduce several key factors. An increase in pressure within the great arteries is a primary factor for increasing afterload. This pressure rise is commonly due to increased systemic vascular resistance, such as in systemic hypertension, where the heart literally has to push harder against constricted vessels.
High blood pressure.
Exactly. Surprisingly, acute increases in contractility can also transiently increase systolic pressure, thereby increasing the load against which the next contraction must occur. An increase in filling volume can increase the radius of the ventricle, and according to the law of Laplace, this directly increases wall tension and thus afterload, even if the systemic resistance isn't primarily elevated.
So a bigger heart faces more afterload.
A bigger radius, yes. Geometric changes within the ventricle, specifically an increased ventricular radius, or conversely, a decreased ventricular wall thickness, like in a dilated, thin ventricle, will also increase afterload. And finally, an increased heart rate can increase the heart's overall oxygen demand, indirectly contributing to afterload by increasing the metabolic burden on the heart, making it less efficient. Conversely, factors that reduce pressure, like vasodilation, decrease the ventricular radius, or increase wall thickness, like appropriate hypertrophy, will lead to a decrease in afterload and, consequently, an increased stroke volume for a given filling volume.
You mentioned ventricular dilation earlier. How does a big dilated ventricle, especially common in heart failure, play into this concept of afterload and the law of Laplace? This seems like a particularly cruel paradox.
It is indeed a cruel paradox and a key component of the vicious cycle in heart failure. A big dilated ventricle, which you frequently observe in advanced heart failure, inherently has an increased radius.
Right, R goes up in the equation.
Precisely. According to the law of Laplace, this immediately and significantly increases the wall stress or afterload that each individual muscle fiber must generate to pump blood. This higher wall stress, in turn, drastically increases the heart's oxygen demand, making it work harder and consume more energy. This increased workload, paradoxically, can further reduce its systolic function. So, the very dilation that might initially seem like a compensatory mechanism to accommodate more blood actually creates a greater workload on an already struggling heart, further weakening it.
Wow.
It's a self-destructive feedback loop that perpetuates the decline.
And what are the proposed cellular and structural mechanisms that lead to this detrimental ventricular dilation? How does the heart get big and baggy like that?
The dilation observed in heart failure is a complex process influenced by several neurohormones, primarily noradrenaline, angiotensin II, and aldosterone, which we'll definitely discuss more when we get to compensation. They are proposed to cause ventricular dilation through several key mechanisms. Firstly, by inducing cell lengthening of individual cardiomyocytes, effectively causing the heart muscle cells to stretch and elongate. Secondly, through widespread cell death, either by apoptosis or necrosis. When cardiomyocytes die, the remaining viable cells in the syncytium can literally slip apart relative to each other, leading to overall chamber enlargement.
Myocyte slippage.
Exactly. Another contributing mechanism is the disruption of the collagen matrix that structurally supports and holds the cardiac cells together. Damage or remodeling of this extracellular matrix again allows for myocyte slippage and subsequent pathological dilation. All these contribute to a larger, yet less efficient cardiac chamber.
You touched on apoptosis and necrosis as forms of cell death contributing to dilation. Can you quickly differentiate those processes for us and what specifically mediates them in the context of cardiac cells? Thinking about what our listeners might see on pathology reports.
Certainly. While both apoptosis and necrosis lead to cell deaths and can contribute to cardiac dysfunction, they represent fundamentally different processes. Apoptosis is a programmed, regulated, or predefined cell death, often described as a cellular suicide.
Neat and tidy death.
Relatively speaking, yes. It's a highly controlled process where the cell essentially dismantles itself without causing significant inflammation. In the heart, it can be mediated by factors such as the chronic activation of the renin-angiotensin system via angiotensin II and/or aldosterone, excessive sympathetic nervous system activation and high levels of noradrenaline, sustained calcium overload within the cells, the release of specific cytokines like TNF-alpha, periods of decreased oxygen availability, hypoxia, or the generation of harmful oxygen-free radicals like superoxides. Apoptosis is often seen as a slow, insidious form of cell loss that contributes to chronic remodeling. Necrosis, on the other hand, is an accidental or unregulated cell death, often a more chaotic and catastrophic process that typically does lead to an inflammatory response.
Messy death.
You could say that. In the context of the heart, it's frequently triggered by acute, severe insults like prolonged ischemia, lack of blood flow, leading to a myocardial infarction. Some of the mediators overlap with apoptosis, such as noradrenaline excess, calcium overload, decreases in oxygen, and oxygen-free radicals. However, uniquely, necrosis can also be directly caused by severe infectious agents. For example, certain bacteria or viruses, various potent toxins, or even specific anti-cancer immunosuppressive drugs. These latter factors do not typically induce programmed apoptotic pathways.
Okay.
So while both ultimately result in cell loss and can contribute to ventricular dilation, their underlying mechanisms, triggers, and consequences for the surrounding tissue are quite distinct, with necrosis often involving a more acute inflammatory burden.
Finally, let's briefly touch on the fourth determinant of stroke volume, heart rate. We know it's part of the cardiac output equation, CO equals SV x HR, so a higher heart rate seems intuitively good for output. But how does it actually impact stroke volume, and why is there an optimal range?
That's a critical nuance. While heart rate is indeed directly proportional to cardiac output within a healthy physiological range, an excessively high heart rate can actually have a profoundly detrimental effect on stroke volume. When the heart beats too fast, there's simply insufficient time for the ventricles to adequately fill during diastole.
Right, we mentioned that with preload factors.
Exactly. The significantly reduced filling time directly decreases the end diastolic volume, which, by the Frank-Starling mechanism, ultimately reduces the stroke volume for that beat. Furthermore, a very high heart rate dramatically increases the heart's overall oxygen demand as it's working faster and often less efficiently. This increased metabolic burden can contribute to myocardial ischemia, insufficient blood flow to the heart muscle itself, and potentially worsen afterload, particularly in a compromised heart.
So it's a balancing act.
Precisely. While a modest increase in heart rate can boost cardiac output, there's an optimal balance. Beyond a certain point, the trade-off of reduced filling time and increased oxygen demand means that higher heart rates become counterproductive for stroke volume and overall cardiac efficiency. It becomes a case of diminishing returns and then active detriment.
That's a truly comprehensive breakdown of the heart as a pump and the intricate dance of its stroke volume determinants. We've meticulously built our understanding of the heart's intricate machinery. Now, let's pivot to the agonizing reality of what happens when even this marvel succumbs to relentless stress, when it can no longer meet the body's needs. So what does this accumulation of physiological knowledge mean for the patient experience when they face heart failure? How will our listeners see this play out?
Yeah, this is where we apply all those physiological principles to understand disease, moving from mechanism to manifestation. Congestive heart failure, CHF, is not a specific disease, but rather a complex pathophysiological state. It's defined as a condition where impaired cardiac function renders the heart unable to maintain an output sufficient for the metabolic requirements of the body's tissues and organs, typically at rest or during normal activity.
Unable to keep up.
Right. In a smaller subset of cases, it can also be triggered when the body's metabolic demands are greatly increased, such as in severe hyperthyroidism or profound anemia, overwhelming even a relatively healthy heart. Fundamentally, CHF is characterized by either a primary decrease in cardiac output to the body or a damming of blood back into the venous system, leading to congestion in the lungs or periphery. Oftentimes, it's both.
What are the main ways cardiac dysfunction actually leads to this complex state of heart failure? Are there specific pathways that converge on this diagnosis that students should recognize?
The sources highlight 6 major mechanisms of cardiac dysfunction that can culminate in heart failure. Firstly, and most commonly, failure of the pump itself. This manifests as either systolic dysfunction, where the heart muscle contracts weakly and cannot properly eject blood, leading to a reduced ejection fraction. Or it can be diastolic dysfunction, where the heart muscle cannot relax sufficiently to permit adequate ventricular filling, even if its ability to contract is preserved.
Okay, systolic weak pump, diastolic stiff pump.
That's a good way to think of it. Secondly, obstruction to flow, typically due to narrowed or stenotic valvular structures, which increase the pressure within the ventricular chambers, forcing the heart to work against excessive resistance. Thirdly, regurgitant flow, again often caused by leaky valvular lesions, where blood flows backward rather than forward through the circulation, leading to inefficient pumping. Fourthly, shunted flow, which can be due to congenital heart defects or acquired defects, causing blood to bypass the normal circulatory path, effectively wasting cardiac output.
Leaky valves or holes in the heart.
Essentially. Fifth, disorders of cardiac contraction beyond just pump failure, such as severe persistent arrhythmias, like a rapid atrial fibrillation that prevent effective coordinated pumping. And finally, although less common as a chronic cause, rupture of the heart or major vessel, leading to a sudden and catastrophic loss of circulatory continuity, all these mechanisms ultimately impair the heart's ability to maintain adequate forward flow or prevent backward congestion.
Now, when the heart begins to falter, the body doesn't just passively give up. It tries to compensate, often desperately. But as we know in medicine, these short-term fixes can often become long-term problems, paradoxically making things worse. What are these critical compensatory mechanisms, and how do they initially help but then harm the failing heart? This seems key for understanding the progression.
That's an excellent and crucial point for understanding heart failure progression. There are three main compensatory mechanisms, all initially adaptive and life-saving, but which, over time, become maladaptive and deleterious, perpetuating the disease. The first is the Frank-Starling mechanism itself, which we just explored.
Right, the stretch mechanism.
Exactly. When the heart's pumping ability is initially reduced, the body responds by increasing end-diastolic filling volume through fluid retention and venous constriction. This dilates the heart, stretches the myocardial fibers, and according to the Frank-Starling law, leads to a more forceful contraction. This can initially increase cardiac output back to near normal levels, leading to what we refer to as compensated heart failure. The patient feels relatively well at rest, but they are operating at a higher preload.
So they look okay, but internally things are stressed.
Precisely. However, with time, the failing muscle may become overstretched, stiff, or otherwise damaged, reaching the plateau of the Frank-Starling curve, where further stretch yields no additional benefit or even detriment. At this point, it can no longer propel sufficient blood, even with increased filling, leading to decompensated heart failure, where symptoms become overt. The initial fix becomes exhausted and insufficient.
So the body tries to stretch the heart to compensate. What about the body's hormonal and nervous system responses? They seem to be major players in this long-term deterioration, the ones we often target with drugs.
Indeed, that's the second major mechanism, the activation of neurohumoral systems, which is a cascade of hormonal and nervous responses. The most immediate is the sympathetic nervous system, SNS. A fall in cardiac output is rapidly detected by baroreceptors in the carotid sinus and aortic arch, triggering an increased release of noradrenaline from sympathetic nerve endings.
Fight or flight kicks in again.
Right. This initially increases heart rate and directly supports myocardial contractility, helping to maintain blood pressure. It also causes widespread venoconstriction, redistributing blood from the periphery to the central circulation, thereby increasing cardiac preload, and arteriolar constriction to help maintain systemic blood pressure and perfusion to vital organs. While acutely beneficial in maintaining circulation in an emergency, chronic excessive SNS activation is profoundly deleterious.
Why is that bad long-term?
It continuously increases afterload on an already struggling heart, leading to increased workload and oxygen demand. Moreover, sustained high levels of catecholamines can directly cause desensitization and downregulation of beta receptors on the heart, making it less responsive to sympathetic stimulation over time and contributing to myocyte toxicity and apoptosis.
Okay. And the other big one, RAAS.
Then there's the notorious renin-angiotensin-aldosterone system, RAAS. This system is powerfully activated by decreased renal perfusion, which naturally occurs with reduced cardiac output, and also by direct SNS stimulation of the kidney's juxtaglomerular cells. Renin release initiates a complex cascade. Renin converts angiotensinogen, a liver protein, into angiotensin I. This angiotensin I then travels to the lungs and other tissues where it is converted to the highly active angiotensin II by the angiotensin-converting enzyme, ACE.
Angiotensin II, the main culprit.
It's a major player. Angiotensin II has two primary and detrimental effects in heart failure. First, it directly stimulates aldosterone release from the adrenal cortex. Aldosterone then promotes significant sodium and water retention by the kidneys, leading to increased blood volume and thus increased preload. Second, angiotensin II causes widespread and potent vasoconstriction by acting on AT1 receptors in the vascular smooth muscle, significantly increasing vascular tone and thus afterload on the heart.
So more volume and more resistance. Double whammy.
Exactly. Both effects initially help maintain blood pressure and perfusion, but chronically they relentlessly overload the heart with fluid and pressure and also directly promote adverse myocardial hypertrophy and cell death, contributing to remodeling. Balancing RAAS, the atrial natriuretic peptide ANP, a beneficial counter-regulatory hormone, is released by atrial stretch in response to increased volume. ANP promotes diuresis and vasodilation, attempting to counteract the RAAS, but often its effects are overwhelmed in chronic heart failure.
So we have the heart trying to pump harder through stretch, and the neurohormonal systems trying to maintain blood pressure and volume. What's the third major compensatory mechanism, and how does it contribute to the long-term pathology? This seemed to relate back to the law of Laplace.
The third crucial mechanism involves myocardial structural changes, specifically hypertrophy and remodeling. Unlike most cells, mature cardiac myocytes cannot proliferate, but they can dramatically increase in size, a process known as hypertrophy. This occurs in response to chronic wall tension, whether from sustained high preload, volume overload, or high afterload, pressure overload, and also directly influenced by neurohormones like angiotensin II and norepinephrine. Initially, hypertrophy is genuinely compensatory. By adding more contractile elements and making the muscle thicker, it aims to increase the heart's pumping force and reduce the wall tension towards more normal levels, maintaining output.
Makes the muscle bigger to cope.
Right. However, this compensation comes at a significant cost and often transitions into pathological remodeling, a key feature of progressive heart failure. We can apply the law of Laplace here again. If there's an increased chamber diameter due to excessive preload, volume overload, it typically leads to eccentric hypertrophy, where the muscle fibers elongate, making the ventricular wall stretch and thin while the chamber enlarges. Think of a balloon getting bigger but thinner walled.
Eccentric, dilated.
Essentially. If there's sustained high afterload, pressure overload, it results in concentric hypertrophy, where muscle fibers grow in diameter, causing the wall to thicken significantly inwards, reducing the chamber volume. Think of making the walls of a room thicker, reducing the usable space inside.
Concentric thickened.
Okay. While initially adaptive, chronic hypertrophy and relentless neurohormonal activation can trigger further detrimental internal remodeling. This includes a continuous loss of functional myocytes through apoptosis, the excessive accumulation of stiff fibrous tissue, fibrosis, which makes the heart less compliant, abnormal energy production within the struggling cells, and further progressive ventricular dilation. This leads to a less functional, stiffer, and ultimately weaker heart, worsening the failure and significantly increasing the risk of life-threatening arrhythmias. It creates a relentless, self-perpetuating vicious cycle where the very mechanisms meant to save the heart end up condemning it.
That's a very clear and rather grim picture of the body's desperate struggle. Let's delve into the different ways heart failure can manifest, as not all heart failure is the same. How do we categorize the types of heart failure based on functional abnormalities, and why is this distinction important for patient care? You need to know what type you're dealing with, right?
Absolutely. We primarily recognize 3 functional types, and distinguishing them is absolutely critical for targeted diagnosis and management. The first is systolic heart failure, which is fundamentally a problem with the heart's ability to contract and eject blood. This often occurs when a part of the ventricle has been damaged, for instance, by a myocardial infarction, meaning some muscle tissue is dead or severely impaired and cannot contract effectively.
The weak pump again.
Right. As a consequence, the heart ejects a decreased stroke volume, leaving a large amount of blood behind in the ventricle after each beat. This residual volume leads to a massively increased filling volume and critically increased pressure in the ventricle during diastole because there's simply too much blood trying to get in. By recruiting the Frank-Starling mechanism, this massively increased filling volume can initially return the stroke volume back to normal at rest, but it's always at the expense of these very high filling pressures, leading to congestion.
And the key marker here is?
The key marker for systolic heart failure is a reduced ejection fraction, which is the percentage of blood ejected from the ventricle with each beat. A normal ejection fraction is typically above 50–55%. In systolic heart failure, it's often significantly lower, leading to cardiac dilation. We often call this HFrEF heart failure with reduced ejection fraction.
HFrEF, got it. And the second type, diastolic heart failure, seems to be a problem with relaxation rather than contraction. How does that manifest differently?
Exactly. The second type is diastolic heart failure. Here, the primary problem isn't with the heart's ability to contract forcefully, but with its inability to adequately fill the ventricle during diastole.
The stiff pump HFpEF, heart failure with preserved ejection fraction.
Precisely, HFpEF. This isn't due to an increased filling volume, but rather because the myocardium itself is stiff and non-compliant, perhaps from concentric hypertrophy, or there's external compression from fluid within the pericardial space, or the pericardium itself is stiff. As a result, filling pressures are raised in diastole despite the ventricle not filling properly. Patients with diastolic heart failure can still increase contractility with exercise as their pumping ability is preserved, but they have inadequate increases in filling volume due to the stiffness.
So they can't boost output when needed.
Right. This inadequacy ultimately leads to exercise intolerance, even if their resting contractility appears normal, so their ejection fraction might be preserved, but their ability to increase cardiac output with demand is severely limited by filling issues.
And the third type, high output heart failure, sounds a bit counterintuitive for a condition called heart failure. Why is the heart failing if it's producing a high output?
It does sound counterintuitive, and it's a crucial distinction. High output heart failure occurs not because the heart muscle itself is inherently weak or damaged, but because of greatly increased metabolic demands or chronic increases in venous return that even a healthy heart simply cannot keep up with over time.
Like what kind of conditions?
Classic examples include severe renal failure due to massive volume overload, profound anemia, where tissues demand more oxygen delivery per unit of blood, hyperthyroidism, which increases overall metabolic rate, or severe thiamine deficiency, beriberi. In these states, high filling volumes cause a significant shift along the Frank-Starling curve, resulting in an increased stroke volume at rest, often even supernormal compared to a healthy individual. However, this is always at the expense of massively increased filling pressures.
High pressure despite high output.
Exactly. And critically, these patients still experience exercise intolerance because even though their resting stroke volume is high, their heart is already operating on the plateau of its Frank-Starling curve. It cannot adequately increase stroke volume further to meet the extraordinary demands of exercise or stress, leading to classic symptoms of heart failure despite high resting output. The heart is failing to meet an abnormally high demand, not failing because it's inherently weak.
So we have these functional classifications, HFrEF, HFpEF, high output.
Yeah.
But how does failure on one side of the heart impact the other? And what are the distinct clinical presentations for left versus right-sided failure, giving us critical clues for diagnosis when you see a patient?
Yeah, the heart, while one organ, effectively acts as two pumps in series. Left-sided heart failure is by far the most common form, typically caused by ischemic heart disease, like a history of myocardial infarction, systemic hypertension, chronic mitral or aortic valvular disease, or primary myocardial diseases like dilated cardiomyopathy or amyloidosis. Its key consequences are twofold. Diminished systemic perfusion, meaning not enough blood reaches the body's tissues and organs, and crucially, elevated back pressures within the pulmonary circulation, causing blood to dam up in the lungs.
Lungs, so shortness of breath. What are the specific findings you'd expect to see in a patient presenting with left-sided heart failure, whether on imaging or clinically?
Exactly. Lungs are key. In the heart itself, depending on the underlying cause, you might find left ventricular hypertrophy due to chronic pressure overload from hypertension, which eventually progresses to dilation of the left ventricle as it attempts to compensate but then fails. In the lungs, the rising pressure in the pulmonary capillaries and arteries leads directly to pulmonary congestion and severely pulmonary edema. This makes the lungs heavy and boggy with fluid impairing oxygen exchange. You might even find heart failure cells in the sputum. These are macrophages that have phagocytosed red blood cells that leaked into the alveolar spaces from congested capillaries, a histological hallmark you might see. Systerically, the decreased cardiac output leads to decreased renal perfusion, which in turn powerfully activates the RAAS, causing further fluid retention and blood volume expansion, perpetuating the cycle. In the brain, patients can present with subtle changes like irritability, restlessness, or in severe cases, even coma due to cerebral hypoxia. Clinically, patients with left-sided heart failure commonly present with shortness of breath, dyspnea, particularly on exertion. This often worsens to orthopnea, dyspnea when lying flat, as fluid redistributes to the lungs, and paroxysmal nocturnal dyspnea, PND, which is a sudden awakening at night with severe breathlessness and anxiety.
PND, scary stuff.
Very. Other signs include cardiomegaly, an enlarged heart on chest x-ray, tachycardia, heart trying to compensate, and signs of decreased renal perfusion like reduced urine output.
And what about right-sided heart failure? Is it always a consequence of left-sided failure, or can it occur in isolation?
Right-sided heart failure is indeed most often a consequence of left-sided heart failure, as the increased pressure in the pulmonary circulation, pulmonary hypertension, places an increased chronic burden on the right side of the heart, eventually causing it to fail.
So the left fails, backs up into the lungs, which then stresses the right side.
That's the usual sequence. However, isolated right-sided heart failure can occur, most notably in severe pulmonary hypertension, a condition specifically termed cor pulmonale. The hallmark of right heart failure is the engorgement of the systemic and portal venous systems as blood backs up from the right ventricle into the body's veins.
So what does that look like clinically? Swelling.
Yes, prominent swelling. Clinically, you'll see hepatomegaly, or an enlarged liver, often described as a nutmeg liver due to its congested appearance on cross-section, which, if persistent and severe, can lead to cardiac cirrhosis. You can also find splenomegaly, an enlarged spleen. Effusions are common in various body cavities, pleural around the lungs, pericardial around the heart, and peritoneal, a site splued in the abdomen. These are typically transudates, meaning they are clear, watery fluids, low in protein due to increased hydrostatic pressure. Peripheral edema in the subcutaneous tissue, often bilateral and pitting, meaning it leaves an indentation when pressed, is also characteristic, usually worse in the legs and dependent areas. In severe generalized cases, this massive edema is called anasarca. A raised jugular venous pressure, JVP, is a key sign of elevated right atrial pressure, often with a positive abdominojugular reflux, where pressing on the liver causes the JVP to transiently rise further. Patients with isolated right heart failure tend to have few primary respiratory symptoms unless their pulmonary hypertension is very severe, but they present with prominent signs of systemic venous congestion.
That paints a very clear picture of the distinct presentations. So what are the unifying clinical manifestations and diagnostic clues that we should always be looking for in any type of heart failure, regardless of which side is affected or the specific underlying cause? Are there universal truths in heart failure that students should latch onto?
Yeah, there are. Regardless of the underlying mechanism or site affected, two key factors are common to all forms of heart failure. First, raised filling pressures. This means persistently increased pressure within the atria and/or ventricles during diastole. When these pressures are high, blood flow from the atrium into the ventricle during early diastole becomes turbulent as it's forced into an already high-pressure chamber. This turbulence manifests clinically as an abnormal third heart sound, S3, often described as a Kentucky gallop.
Lub-dub, D-U-B, Kentucky.
Exactly. It indicates rapid ventricular filling into an overloaded or non-compliant ventricle. The S3 is a crucial marker of high filling pressures and strongly suggests volume overload in heart failure. Second, and equally important clinically, is exercise intolerance. This is perhaps the most common and debilitating symptom. It means the heart is unable to adequately increase stroke volume with activity compared to a normal person, even if the resting stroke volume might be near normal due to compensatory mechanisms.
Can't keep up with demand.
Right.
The severity of heart failure is often graded by the level of activity at which shortness of breath or fatigue occurs, ranging from dyspnea on extreme exertion to dyspnea at rest. At its most severe, in conditions like cardiogenic shock, the patient experiences shortness of breath and profound fatigue even at rest, because stroke volume and contractility are dramatically reduced, irrespective of increased filling volume, leading to critical hypoperfusion. What are the common symptoms patients report and signs you'd find on examination that point to heart failure? Things for students to look and listen for.
Common symptoms patients report include chronic edema, both peripheral, like swollen legs and ankles, and pulmonary, leading to breathlessness. Shortness of breath, dyspnea, is omnipresent, whether it's at rest, on exertion, or specific patterns like orthopnea, dyspnea when lying flat, alleviated by sitting up, and paroxysmal nocturnal dyspnea, PND, sudden awakening at night with severe anxiety and suffocation requiring sitting up or even standing. Patients also frequently report profound fatigue, sometimes chest pain due to ischemia from increased myocardial oxygen demand or high pressures, early satiety, nausea, and abdominal pain from visceral congestion of the liver and gut.
Gut symptoms too. Yes, from the backup of fluid. Other less specific but important symptoms include nocturia, frequent urination at night due to fluid mobilization when supine, syncope or syncope, fainting or near fainting, due to inadequate cerebral perfusion, and confusion in more severe cases. On physical examination, you might observe obvious labored breathing and an inability to finish sentences due to dyspnea. Blood pressure and heart rate can be variable, but often there's tachycardia and signs of poor perfusion and a low pulse pressure, the difference between systolic and diastolic BP. The aforementioned edema is typically dependent in the lowest parts of the body, bilateral and pitting, often worse in the evening, and elevated jugular venous pressure, JVP, which shows congestion in the neck veins, often with a positive abdominojugular reflux.
Checking the neck veins.
Exactly, is a significant sign of right atrial pressure overload. Cardiac examination may reveal a displaced apex beat, the lowest and outermost point where the heart impulse is felt shifted due to dilation, a peristernal heave or thrill, palpable pulsations indicating right ventricular hypertrophy, and abnormal heart sounds, including the S3 we discussed earlier. Lung examination may show tachypnea, rapid breathing, crackles, or rales, at the lung bases from pulmonary edema, and often a pleural effusion, fluid accumulation in the lung space, typically right-sided. Abdominal examination might reveal jaundice, yellowing of skin from liver congestion, a distended abdomen from ascites, hepatomegaly, enlarged liver, which can be tender and even pulsatile, and splenomegaly. It's truly a systemic syndrome.
It's clear that heart failure has a wide array of presentations, and we need to be vigilant in our assessment. What about the things that can precipitate or reversibly cause heart failure? Identifying these seems crucial because addressing them can often dramatically improve a patient's condition, right?
Identifying these is indeed paramount, as managing them can prevent a decompensation or even improve chronic heart failure. Common precipitants and reversible causes include anemia, which forces the heart into a high output state to compensate for reduced oxygen carrying capacity. Infections, such as pneumonia or sepsis, increase metabolic demands on the body and can directly affect the myocardium. Arrhythmias, particularly a rapid atrial fibrillation, can significantly impair ventricular filling and reduce cardiac output.
Like AFib.
Exactly. Hyper or hypothyroidism both alter cardiac workload, with hyperthyroidism causing increased demands and hypothyroidism leading to weakened contraction. Pregnancy increases circulatory volume and cardiac output demands. Acute events like a new myocardial infarction, heart attack, or a pulmonary embolism, blood clot in the lung artery, can acutely overwhelm the heart. Uncontrolled severe hypertension relentlessly increases afterload. And critically, inadequate treatment of underlying cardiac conditions or, sadly, non-compliance with prescribed medications or lifestyle changes are frequent culprits for decompensation.
So adherence is key.
Absolutely. For diagnosis, while the clinical picture is paramount, objective tools like a chest X-ray can reveal a dilated heart, cardiomegaly, evidence of pulmonary edema, like curly bee lines or interstitial fluid, confirming the presence of congestion and aiding in the diagnosis.
That brings us to our next major section. We've talked about the heart as a pump and the general state of heart failure. Now let's explore specific diseases of the heart muscle itself and its surrounding structures that cause failure. So when we talk about the heart muscle itself, what are we really looking at in terms of intrinsic conditions?
Right. This section delves into the intrinsic diseases of the myocardium, the heart muscle, and the pericardium, the sac surrounding the heart. We'll start with cardiomyopathies, which literally means disease of the heart muscle. These are a heterogeneous group of diseases of the myocardium that are associated with mechanical and odd or electrical dysfunction. They often result in inappropriate ventricular hypertrophy, thickening, or dilation enlargement, and are not due to other conditions like hypertension or valvular disease.
So it's the muscle itself that's the primary problem.
Correct. They stem from a variety of causes, frequently genetic, and can either be confined to the heart, primary cardiomyopathies, or be part of generalized systemic disorders, secondary cardiomyopathies. A major advance in our understanding has been the identification of underlying genetic causes, often mutations in genes that encode proteins of the sarcomere, the contractile unit, the cytoskeleton, the cell's scaffolding, or proteins involved in ion transport. These mutations lead to abnormal contraction, relaxation, or electrical dysregulation.
What are the three main pathological patterns of cardiomyopathy our listeners should know, and how do they manifest clinically?
There are three distinct pathological patterns. The most common, accounting for about 90% of all cardiomyopathy cases, is dilated cardiomyopathy, DCM. Here, the heart is typically significantly enlarged and weak, with all four chambers dilated. Its causes are diverse. Genetics account for 20–50% of cases, often involving mutations in sarcomeric or cytoskeletal genes like dystrophin. Other significant causes include viral myocarditis, post-viral damage, toxins like chronic alcohol abuse or certain chemotherapeutic agents, for example, anthracyclines, pregnancy-related factors, peripartum cardiomyopathy, and iron overload conditions such as hemosiderosis and hemochromatosis.
So lots of potential causes for DCM.
Yes. Morphologically, a DCM heart is globoid, enlarged, and flabby, with microscopic interstitial fibrosis. Clinically, it's characterized by inefficient contraction, with the heart struggling to pump blood forward. The ejection fraction is typically severely reduced, often less than 25% in end-stage disease. Patients present with slow, progressive congestive cardiac failure. Without a cardiac transplant, the prognosis is often poor, with many patients facing a high mortality rate within a few years.
And the second type, hypertrophic cardiomyopathy, I've heard is a common cause of sudden death, especially in young athletes. What makes it so dangerous?
That would be hypertrophic cardiomyopathy, HCM. This condition is almost exclusively genetic, caused by mutations in several genes that encode proteins of the contractile apparatus, such as beta-myosin heavy chain or cardiac troponin T. It's usually inherited in an autosomal dominant pattern. It's surprisingly common, affecting about 1 in 500 individuals.
1 in 500, that's quite common.
It is. Morphologically, the heart is thick-walled, heavy, and often appears hypercontracting. The key diagnostic feature is a disproportionate and asymmetrical thickening of the ventricular septum relative to the left ventricular free wall, leading to a smaller left ventricular cavity.
Thick septum.
Right. Clinically, HCM is primarily a disorder of diastolic dysfunction, meaning the heart has impaired filling and reduced compliance due to its stiffness, even though systolic function, the ejection of blood, is usually preserved or even supernormal. Stroke volume is often reduced not because of weak contraction, but because the smaller, stiff chamber simply cannot fill adequately. About 25% of patients also experience dynamic left ventricular outflow obstruction, where the thickened septum can physically block blood flow during systole, creating a functional stenosis.
Blocking the exit.
Exactly. This outflow obstruction, along with a predisposition to ventricular arrhythmias due to the disorganized myocardial architecture, is a major cause of sudden cardiac death, particularly in young athletes, explaining those tragic headlines. Patients can also develop arrhythmias like atrial fibrillation, thrombi leading to stroke, and eventually classic heart failure symptoms. Pharmacological interventions like beta blockers are crucial as they decrease heart rate and contractility, which helps reduce outflow obstruction and improves diastolic filling time.
Finally, the least common type of cardiomyopathy.
That's restrictive cardiomyopathy, RCM. This is characterized by a primary decrease in ventricular compliance, meaning the ventricles become stiff and rigid, leading to severely impaired ventricular filling during diastole. Crucially, contractile function is often preserved.
Stiff again, like diastolic failure, but the cause is different.
Yes, the underlying cause leads to stiffness. It can be idiopathic, of unknown cause, or more commonly associated with systemic disorders. These include infiltrative diseases like amyloidosis, where abnormal proteins like amyloid light chains deposit in the myocardium, sarcoidosis, a granulomatous inflammatory disease, hemochromatosis, iron overload, radiation fibrosis, damage from radiotherapy, or even metastatic tumors infiltrating the heart. Morphologically, the ventricles are typically normal inside or only slightly enlarged, and their cavities are not dilated. The myocardium feels firm and non-compliant, and biatrial dilation, enlargement of both atria, is commonly observed as blood backs up. RCM can sometimes be confused with constrictive pericarditis or severe HCM due to the similar clinical presentation of impaired diastolic filling and signs of venous congestion, making careful diagnosis critical.
Now let's talk about myocarditis, the inflammation of the heart muscle. You mentioned its potential for sudden death, especially in young adults. Myo means muscle, cardio means heart, unitis means inflammation. So what exactly is causing this inflammation here, and why is it such a concern?
Myocarditis is indeed an inflammatory disease of the myocardium, resulting in injury to and necrosis of cardiac myocytes. It's crucial to differentiate it from ischemic injury, like a myocardial infarction, where inflammation is a response to tissue necrosis. In myocarditis, the inflammatory process is the primary cause of the myocardial injury itself.
Inflammation first, then damage.
Exactly. While it can range from asymptomatic or mild symptoms to fulminant cardiogenic shock, post-mortem data suggests it accounts for a significant percentage, between 8.6% and 12% of sudden deaths in young adults, making it a critical, often silent threat.
So what ignites this inflammation in the heart? What are the usual suspects?
The etiology can be broadly classified into infectious and non-infectious causes. Among infectious causes, viral myocarditis is overwhelmingly the most common, frequently caused by enteroviruses like Coxsackie virus A and B, and adenoviruses, especially serotypes 2 and 5.
Common viruses.
Very common. However, bacterial agents like Staphylococcus aureus, Corynebacterium diphtheriae, fungal, example, Candida aspergillus, Parasitic, for example, Trypanosoma cruzi causing Chagas disease. Rickettsial and spirochetal agents, like Borrelia burgdorferi causing Lyme carditis or Mycobacterium tuberculosis in endemic areas, can also cause it. Non-infectious causes include autoimmune disorders, for example, systemic lupus erythematosus, sarcoidosis, giant cell myocarditis, hypersensitivity reactions to certain drugs like methyldopa, sulfonamides, exposure to toxins, chronic alcohol abuse, cocaine, heavy metals like lead or arsenic, radiotherapy to the chest, and rarely severe thyrotoxicosis.
How does this inflammation progress through different phases, and how does that influence the clinical picture you might see?
The pathogenesis of myocarditis typically unfolds in three overlapping phases. The acute phase, occurring within days of exposure, involves the direct entry of a pathogen, for example, virus, into myocytes. This leads to direct cellular damage and necrosis, which then rapidly stimulates the innate immune system. In the subacute phase, typically days to weeks later, it's actually the subsequent immune and inflammatory response, involving lymphocytes, macrophages, and cytokines, that causes further myocardial damage, often disproportionate to the initial insult. This ongoing inflammation can lead to further myocyte destruction and early fibrosis.
So the body's response causes more damage.
Often, yes. Finally, the chronic phase, weeks to months later, often presents with features resembling dilated cardiomyopathy due to persistent myocardial inflammation, ongoing myocyte loss, and extensive fibrosis, leading to a chronically weakened and dilated heart.
And what are the clinical features, and how do we confidently diagnose it, given its varied presentation? This sounds tricky.
Clinical features are highly variable, making diagnosis challenging. They range from asymptomatic or mild ECG changes to symptoms mimicking an acute myocardial infarction, such as sudden onset chest pain, shortness of breath, and elevated troponins, or even progressing rapidly to acute cardiac failure or cardiogenic shock. Patients might also experience a variety of arrhythmias, from benign palpitations to life-threatening ventricular tachycardias. If there's concurrent pericarditis, you may hear a characteristic pericardial friction rub.
So it can look like a heart attack.
It certainly can. Diagnosis cannot be made on clinical basis alone due to its mimicry of other conditions. The definitive gold standard diagnosis is endomyocardial biopsy, which involves taking a small sample of heart muscle and looking for the characteristic histological findings of inflammation and myocyte necrosis, specifically the Dallas criteria, lymphocyte infiltration, and myonecrosis.
Biopsies is gold standard. What about less invasive tests?
Nonspecific biomarkers like troponin, highly sensitive for myocardial injury, often more frequently elevated than CKMB, can suggest cardiac injury. An elevated leukocyte count, or C-reactive protein, CRP, may indicate an infectious or inflammatory cause. While ECG changes are nonspecific and can mimic MI, and echocardiograms can show chamber size and function abnormalities, cardiac MRI, CMR, is the most useful non-invasive diagnostic test.
Cardiac MRI.
CMR can detect areas of inflammation, edema, and late gadolinium enhancement, indicating fibrosis, helping to differentiate myocarditis from MI and diagnose chronic myocarditis based on fibrosis and features of DCM. For specific viral causes, viral serology or PCR may be performed.
How is myocarditis typically managed, and what are its potential long-term complications, especially considering its impact on young adults?
Management primarily involves treating the underlying cause, whether it's an infection, for example, antibiotics for bacterial causes, or a non-infectious condition, for example, immunosuppression for autoimmune causes. Crucially, limiting physical activity is essential to reduce cardiac workload and allow for myocardial healing. Vigorous exercise is strictly prohibited during the acute phase.
Rest is important.
Very. Supportive care is also paramount, managing any complications that arise, such as heart failure symptoms with diuretics or arrhythmias with antiarrhythmics. Immunoglobulins and immunosuppressive therapies like corticosteroids remain controversial, generally reserved for specific severe or autoimmune forms. The major complications include arrhythmias, which can be life-threatening. A significant concern is the development of dilated cardiomyopathy, DCM, which occurs in about 21% of patients long-term per follow-up studies, leading to chronic heart failure. Ultimately, myocarditis can lead to congestive cardiac failure. Prognosis is generally poor in newborns and infants due to high expression of Coxsackie adenovirus receptors in the brain and heart, leading to higher morbidity and mortality, but it tends to improve in older children and adolescents. It's worth noting that direct myocardial damage by HIV itself is uncommon. Often, HIV-associated myocarditis is linked to co-infections, rarely certain antiretrovirals, or even the viral glycoprotein GP120, which may directly inhibit cardiac contractility.
Now, let's move beyond the muscle itself and explore the heart's protective outer layers and what happens when they become inflamed. Pericarditis. This is a common diagnosis that presents in the clinic, isn't it? Chest pain.
Yes, often presenting with chest pain. The pericardium is a vital two-layered sac surrounding the heart, ensuring its proper function and protection. It consists of an outer fibrous layer, which is tough and inelastic, and an inner serous layer. This serous layer is further divided into a visceral component, epipericardium, which adheres to the heart surface, and a parietal component, which lines the fibrous sac. Between these two serous layers is the pericardial cavity, containing a small amount, typically 1550 milliliters of lubricating fluid, allowing the heart to beat freely with minimal friction.
So it's like a protective bag with some lubricant. What does it do?
Its functions are critical. It stabilizes the heart within the mediastinum, limits its motion, provides a physical barrier protecting it from mechanical trauma and infection, and crucially prevents excessive dilation of the heart chambers during sudden increases in intracardiac volume. Pericarditis refers to the inflammation of these pericardial layers. This inflammation can manifest in different ways: as acute pericarditis, the classic inflammatory syndrome, as pericardial effusion, fluid accumulation within the pericardial cavity, or as constrictive pericarditis, a hardened, fibrous pericardium that severely restricts cardiac filling, a late complication.
What are the common causes of pericarditis, and how does the body respond to this inflammation? Similar causes to myocarditis.
The etiology of pericarditis is broad, much like myocarditis. Infectious causes are common, with viruses being the most frequent culprits, especially Coxsackie virus, echovirus, adenovirus, HIV. Bacterial infections, baby G, staphylococcus, streptococcus, or even Mycobacterium tuberculosis in endemic areas like ours, fungal and parasitic infections can also cause it. Non-infectious causes include autoimmune disorders, for example, systemic lupus erythematosus, rheumatoid arthritis, neoplasms, metastatic cancers or primary pericardial tumors, radiation therapy to the chest, renal failure leading to uremia, traumatic cardiac injury, for example, post-cardiac surgery or direct chest trauma, and myocardial infarction, Dressler's syndrome. Often the cause is idiopathic, meaning no clear reason is found, though many of these are presumed viral.
Idiopathic, meaning we don't know.
Right. The pathogenesis involves an inflammatory response within the pericardial layers. This leads to vasodilation of the small vessels, increased capillary permeability causing fluid transudation, leakage into the pericardial cavity, and leukocyte exudation, infiltration of inflammatory cells like neutrophils in acute bacterial pericarditis or mononuclear cells in viral or TB. The type of fluid collected can even offer important diagnostic clues. Serous or serofibrinous fluid often points to viral or idiopathic causes. Suppurative or purulent fluid suggests bacterial infection. Hemorrhagic fluid indicates trauma, malignancy, or TB. And chylous fluid suggests a lymphatic obstruction.
What are the key clinical features a patient would present with, and how do we diagnose pericarditis? You mentioned chest pain.
Patients typically present with chest pain, which is the hallmark symptom. This pain often has specific characteristics. It's sharp, pleuritic, worsens with deep inspiration, retrosternal, behind the breastbone, and frequently radiates to the trapezius ridge, shoulder neck.
Pain gets better leaning forward.
Yes, characteristically, it worsens with lying flat and often improves with leaning forward. Other symptoms include dyspnea due to pain or effusion, and palpitations from associated arrhythmias. A crucial hallmark on physical exam is a pericardial friction rub, which is a high-pitched scratching or squeaking sound heard on auscultation, often best at the left sternal border with the patient leaning forward. There may also be associated systemic symptoms if the cause is an infection, an underlying autoimmune condition, or a malignancy.
How is it diagnosed? That rub sounds pretty specific.
Pericarditis is primarily a clinical diagnosis based on the characteristic chest pain and the presence of a friction rub. While an echocardiogram can illustrate a pericardial effusion, its absence does not rule out pericarditis. Electrocardiogram ECG changes can be present, often diffuse ST elevation and PR depression, but are not always specific. Investigations then aim to identify the underlying infectious or non-infectious cause through blood tests, cultures, or imaging.
How is it managed, and what are its potential complications, especially the more dangerous ones like effusion?
Management primarily involves bed rest to reduce cardiac workload and pain, and effective pain relief using NSAIDs, nonsteroidal anti-inflammatory drugs, or colchicine. Steroids might be used for recurring pericarditis or specific autoimmune causes. Crucially, the underlying cause must be treated, for example, antibiotics for bacterial pericarditis. If the pericarditis is purulent, pus-filled, surgical drainage is often necessary. The main complications are pericardial effusion, which is fluid accumulation that can progress to a life-threatening condition called cardiac tamponade, and chronic constrictive pericarditis, which can ultimately lead to congestive cardiac failure.
We'll focus on those two serious complications, pericardial effusion and especially cardiac tamponade, which is a common and dangerous clinical problem that requires immediate recognition. This is an emergency, right?
Cardiac tamponade is absolutely a medical emergency. A pericardial effusion is an abnormal accumulation of fluid in the pericardial cavity, exceeding the normal small lubricating amount. This fluid, if it accumulates rapidly or in large volumes, increases intrapericardial pressure, negatively impacting heart function by compressing the chambers. Its etiology mirrors that of pericarditis, as it's essentially a complication of pericardial inflammation, but can also occur from trauma, malignancy, or kidney failure. The clinical features depend critically on several factors: the volume of fluid, the rate at which it accumulates, and the inherent compliance characteristics of the pericardium.
So how fast it builds up matters.
Critically, small effusions, even large in volume but accumulated slowly, may cause no hemodynamic abnormalities because the pericardium can stretch. However, large effusions, or even moderate ones that accumulate rapidly, can lead to significant hemodynamic compromise due to cardiac compression. They can also compress adjoining structures, causing symptoms like dysphagia, difficulty swallowing, hoarseness, hiccups from phrenic nerve irritation, and dyspnea from lung compression.
What are the specific signs that point to pericardial effusion, and especially to the medical emergency of cardiac tamponade? What should students look for?
Key specific signs of a significant pericardial effusion include pulsus paradoxus, which is a pathognomonic sign for tamponade. This is a significant drop, greater than 10 mmHg in systolic blood pressure during inspiration.
Pulsus paradoxus. Okay, why does that happen?
It occurs because, during inspiration, venous return to the right heart increases, but the heart is physically constrained by the fluid. This causes the interventricular septum to bulge into the left ventricle, reducing its filling and thus its stroke volume and systolic pressure. Other signs include muffled heart sounds due to the fluid dampening the sounds of the heart beating, and a pericardial friction rub might still be present, although it can disappear as the effusion enlarges. Ewert's sign is a physical sign observed in very large effusions. Dullness on percussion and bronchial breath sounds at the angle of the left scapula due to compression of the left lung base. The most critical triad of signs indicating the medical emergency of cardiac tamponade, which requires immediate intervention, is Beck's triad: hypotension due to critically reduced cardiac output, muffled heart sounds, and raised jugular venous pressure, JVP.
Beck's triad: low BP, muffled sounds, high JVP. Got it. Emergency.
Exactly. These three signs together signify the heart is severely compressed and unable to fill or pump effectively. The definitive treatment for a significant pericardial effusion, especially cardiac tamponade, is pericardiocentesis, which is the urgent percutaneous removal of fluid. This is both a diagnostic procedure, allowing fluid analysis, and a life-saving therapeutic intervention.
And finally, a very serious, often chronic, late complication of pericardial disease, constrictive pericarditis. What happens there?
Constrictive pericarditis is a severe late complication of any pericardial disease. It involves a chronic inflammatory process leading to fibrous thickening and fusion of the pericardial layers, often with calcification. This results in a rigid, inelastic, and stiff pericardial sac that severely restricts cardiac filling during diastole, even though the myocardium itself may be normal.
So the bag around the heart becomes like concrete.
That's a good analogy. Paradoxically, on imaging, the heart can actually appear smaller than normal, encased in this rigid shell, despite the profound heart failure it causes. The primary clinical consequence is progressive congestive heart failure, characterized by elevated venous pressures, peripheral edema, and liver congestion, much like right-sided heart failure. Due to the irreversible scar tissue, the definitive treatment for constrictive pericarditis is often surgical removal of the pericardium, a procedure called pericardiectomy.
Surgery.
Okay.
We've covered a tremendous amount, from the heart's fundamental mechanics to the devastating mechanisms of heart failure and the specific diseases that cause it to fail. Now let's pivot to how we intervene. What tools do we have in our medical toolkit to manage heart failure? It seems clear that a multifactorial pharmacological approach is absolutely necessary to break those vicious cycles we discussed earlier.
It absolutely is. Pharmacological management of heart failure is not just about alleviating symptoms. It fundamentally aims to improve long-term outcomes and, crucially, interfere with those maladaptive compensatory mechanisms that, while initially helpful, ultimately perpetuate the disease. We're essentially trying to reverse the progression of the vicious cycles with these drugs.
Let's start with a very common and often acute problem in heart failure: fluid retention and congestion. What's our first line of defense there, and how do these medications work at the renal level, getting rid of the fluid?
That would be diuretics. They are the initial go-to for symptomatic relief of fluid overload. They cause the kidneys to excrete excess water and sodium, which significantly improves cardiac function by reducing preload, the amount of blood returning to the heart, and alleviating congestion in the lungs and periphery. The most potent are loop diuretics, like furosemide, also known as Lasix. Their mechanism is to powerfully inhibit the Na plus K plus 2Cl importer in the thick ascending limb of the loop of Henle, effectively blocking the reabsorption of a massive 25% of filtered sodium and chloride.
Big effect. High ceiling.
Exactly. They are often called high-ceiling diuretics because they have a very steep dose-response curve and wide dose range, meaning their diuretic effect increases significantly with higher doses. They are primarily used for rapid reduction of pulmonary congestion and peripheral edema in CHF, and also for conditions like hypercalcemia. A notable secondary effect is their ability to increase prostaglandin E2 production, which acts as a vasodilator and venodilator. However, they come with several adverse effects: hypovolemia and hypotension, due to excessive fluid loss, severe hypokalemia, due to increased sodium load at the collecting duct, leading to enhanced potassium exchange for sodium, hypomagnesemia, and, less commonly, hypocalcemia.
Loss of electrolytes is a big one.
Yes, especially potassium. Ototoxicity, hearing damage, can occur, especially when combined with aminoglycoside antibiotics. They can also cause hyperglycemia and hyperuricemia. Importantly, NSAIDs can reduce their efficacy by inhibiting prostaglandin synthesis.
What about thiazides? Are they useful in heart failure, and how do they differ from loops? Are they as strong?
Thiazide diuretics, like hydrochlorothiazide and indapamide, act primarily on the distal convoluted tubule, blocking the reabsorption of about 5–10% of filtered sodium and chloride. They are actively secreted into the lumen at the proximal convoluted tubule. While they're weaker diuretics than loops and primarily used for hypertension due to their effect on reducing total peripheral resistance via sodium elimination from vascular smooth muscle, they can be used synergistically with loop diuretics in heart failure, especially in cases of diuretic resistance.
So maybe add them on sometime.
Exactly. Their adverse effects include hypokalemia, due to aldosterone-independent Na plus K plus exchange at the collecting duct, rare dilutional hyponatremia, hyperglycemia by inhibiting insulin release, increased LDL cholesterol, increased risk of non-melanoma skin cancers, and hyperuricemia due to competition with uric acid for secretion at the PCT.
And to specifically counter the potassium loss from these powerful diuretics, what do we add? Need to protect the potassium.
That's where potassium-sparing diuretics, such as amiloride and triamterene, come in. They are relatively weak diuretics themselves, working by directly blocking epithelial sodium channels in the collecting duct, thereby inhibiting Na plus K plus exchange, independently of aldosterone. Their primary utility in heart failure is not as monotherapy, but rather to prevent potassium loss when combined with thiazides or loop diuretics. Their main adverse effect, understandably, is hyperkalemia, especially when used in conjunction with other drugs that also tend to increase potassium, such as ACE inhibitors, ARBs, or beta blockers, due to reduced renin release.
Makes sense. And spironolactone. That's in this category, but seems more important.
A very important class within this category are the aldosterone antagonists, specifically spironolactone and eplerenone. Spironolactone is a competitive blocker of aldosterone receptors in the collecting duct, leading to potassium retention and sodium loss. Crucially, beyond their diuretic effect, aldosterone antagonists also protect the heart and vascular smooth muscle from aldosterone's chronic negative remodeling effects, such as myocardial fibrosis and collagen deposition, making them vital add-ons in heart failure.
So they do more than just save potassium.
Much more. Although they are weak diuretics, spironolactone has been shown to significantly reduce mortality and morbidity in heart failure patients, particularly by preventing sudden cardiac death. Like the other potassium-sparing diuretics, hyperkalemia and metabolic acidosis are major adverse effects, especially when combined with other RAS inhibitors or beta blockers, requiring careful monitoring of potassium levels. And finally, a newer class that has truly revolutionized heart failure management, initially used for diabetes, are SGLT2 inhibitors. like empagliflozin.
The pagliflozin.
Right. These drugs block the SGLT2 transporter protein in the proximal convoluted tubule of the kidney, preventing the reabsorption of both glucose and sodium. Water passively follows sodium, leading to increased excretion of both. While their exact full mechanism in heart failure is still being elucidated, they clearly eliminate fluid and sodium, reducing preload. But beyond diuresis, they're believed to have profound cardiovascular benefits by improving cardiac energy metabolism, reducing inflammation, promoting positive ventricular remodeling, and potentially improving mitochondrial function.
Game changers, you said.
They really are. However, they can cause adverse effects like hypotension due to excessive diuresis, hyperkalemia, acute renal impairment, and rarely angioedema.
So diuretics handle the fluid and some of the hormonal imbalance, but you highlighted the RAAS as a real bad actor in heart failure, constantly driving those maladaptive changes. How do we target that system pharmacologically, directly interfering with its detrimental effects? This is core HF therapy, right?
The renin-angiotensin-aldosterone system, RAAS, is indeed a major driver of maladaptive changes in heart failure, constantly promoting vasoconstriction, fluid retention, and cardiac remodeling. Understanding its cascade is key to understanding its pharmacological targets. Renin, the rate-limiting step, is released from juxtaglomerular cells in the kidney, typically due to low renal perfusion or sympathetic nervous system activation. Renin then converts angiotensinogen, a protein from the liver, to angiotensin I. Angiotensin I is then converted to the highly active angiotensin II by the angiotensin-converting enzyme, ACE, which is found abundantly in the lungs and other tissues. Angiotensin II is the main effector. It acts on AT1 receptors found on vascular smooth muscle and the adrenal cortex, causing powerful vasoconstriction, which increases afterload, and stimulating aldosterone release, which leads to significant sodium and water retention, increasing preload. It also directly contributes to adverse cardiac remodeling, hypertrophy, and fibrosis.
So we block it with ACE inhibitors.
ACE inhibitors, such as enalapril, lisinopril, and captopril, are cornerstone therapies for heart failure. Their primary mechanism is to block ACE, thereby preventing the conversion of angiotensin I to angiotensin II, which directly reduces both angiotensin II levels and subsequent aldosterone release. Crucially, ACE is also involved in the breakdown of bradykinin, a potent endogenous vasodilator. So ACE inhibitors also inhibit the breakdown of bradykinin, leading to higher bradykinin levels. This contributes to their beneficial vasodilating effects, dropping total peripheral resistance.
Ah, the bradykinin effects explains the cough.
It does. They are widely used in heart failure to reduce both preload and afterload, and landmark trials have shown they significantly reduce HF mortality by 35–40%. Their main adverse effects are a dry, persistent cough in up to 30% of patients due to bradykinin buildup in the larynx-pharynx, and a rarer but life-threatening angioedema, swelling of the deep dermis and mucous membranes, also related to bradykinin. Hyperkalemia and acute kidney injury are also risks. They are contraindicated in pregnancy due to potential fetal renal dysfunction and in bilateral renal artery stenosis, where they can precipitate severe renal failure.
What if a patient develops that dry, persistent cough from ACE inhibitors? Is there an alternative to block the RAAS without the cough?
That's precisely where angiotensin receptor blockers, ARBs, like losartan and valsartan come into play. They directly block the AT1 receptors, preventing angiotensin II from exerting its detrimental effects: vasoconstriction, aldosterone release, remodeling. The key pharmacological difference is that ARBs do not affect bradykinin breakdown, so the risk of cough and angioedema is much lower compared to ACE inhibitors.
So, less cough, same RAAS blockade.
Generally, yes. They offer similar efficacy in heart failure and are typically preferred if ACE inhibitors are intolerable due to cough. However, the risk of hyperkalemia and renal impairment remains similar when combined with other drugs that affect potassium or renal function. A truly game-changing, newer approach for heart failure is the combination of an ARB with a neprilysin inhibitor, like sacubitril.
The ARNIs, sacubitril valsartan.
Exactly. Neprilysin is an enzyme that normally breaks down natriuretic peptides such as ANP and BNP, which are beneficial endogenous peptides that promote diuresis, natriuresis, and vasodilation. By inhibiting neprilysin, sacubitril increases levels of ANP and BNP, leading to beneficial effects such as increased diuresis, natriuresis, vasodilation, increased glomerular filtration rate, and reduced cardiac hypertrophy and fibrosis. However, neprilysin also breaks down angiotensin II and bradykinin. Therefore, sacubitril is always given in combination with an ARB, like valsartan, to block the potential increase in angiotensin II at levels that would otherwise occur.
So you need the ARB to stop the bad effects of angiotensin II while boosting the good ANP-BNP.
Precisely. This combination, called an ARNI, angiotensin receptor neprilysin inhibitor, has been approved for heart failure with reduced ejection fraction and has shown significant reductions in mortality and hospitalizations, truly representing a major advance in therapy. Adverse effects can include hypotension, hyperkalemia, renal impairment, and a risk of angioedema due to increased bradykinin.
Beyond these powerful RAAS inhibitors, what other vasodilators do we have in our arsenal to reduce the heart's workload, either by reducing preload or afterload? Other ways to open the pipes.
We have a few key options that specifically target either the arterial or venous system or both. Hydralazine is an arterial vasodilator. Its mechanism involves acting as a nitric oxide donor, which then activates guanylate cyclase, increasing intracellular cyclic GMP. This ultimately leads to a relaxation of arterial smooth muscle and arterial vasodilation, thereby primarily reducing afterload.
Reduces resistance.
Right. It's often used as a second-line oral agent in heart failure, particularly in combination with isosorbide mononitrate if ACE inhibitors or ARBs are not tolerated, often in specific populations like African Americans. Adverse effects can include reflex renin release, increased heart rate, and a small risk of drug-induced lupus-like syndrome. Then there's isosorbide mononitrate, a potent venodilator. Also a nitric oxide donor, it increases cyclic GMP predominantly in venous smooth muscle. This causes significant venodilation, which increases venous capacitance, essentially pooling blood in the veins.
Reduces preload then, less blood coming back.
Exactly. This pooling reduces the amount of blood returning to the heart, thus powerfully reducing preload. It's used synergistically with hydralazine, providing a balanced approach to reducing both preload and afterload. For acute severe heart failure, particularly in hospital settings, sodium nitroprusside is an intravenously administered balanced veno and arterial vasodilator. It rapidly releases nitric oxide, which increases cyclic GMP in both arterial and venous smooth muscle, causing widespread vasodilation and rapidly reducing both preload and afterload.
Strong stuff for emergencies.
Very potent, very fast-acting. Its very short half-life makes it useful for acutely decompensated heart failure and hypertensive emergencies, as its effects are quickly reversible. However, it requires careful monitoring as it can cause lactic acidosis and cyanide toxicity, especially with prolonged use or in patients with renal impairment, sometimes requiring thiosulfate detoxification.
Next, a drug class that was historically counterintuitive for heart failure, but is now absolutely central to treatment: beta blockers. Why would we use a drug that slows the heart and initially can reduce contractility in a condition where the heart is already failing? This seems like a paradigm shift, as you said before.
This is indeed one of the most profound paradigm shifts in heart failure management. Historically, beta blockers were strictly contraindicated in heart failure because they could acutely worsen pump function by reducing contractility. However, landmark clinical trials such as CVS and Copernicus fundamentally changed our understanding, unequivocally demonstrating a clear and significant improvement in mortality and morbidity in patients with stable systolic heart failure.
So the evidence forced a rethink.
Completely. They are now standard first-line therapy for most patients with heart failure, with reduced ejection fraction, and increasingly recognized for their benefits in diastolic failure as well. Key drugs include carvedilol, which is a non-selective beta blocker that also has alpha-1 blocking properties, giving it beneficial vasodilating effects, and bisoprolol and metoprolol succinate, which are beta-1 selective blockers. The critical point in their administration is that they must be started at very low doses and slowly titrated upwards over weeks to months.
Start low, go slow.
That's the mantra. This slow titration allows the heart to adapt and avoid acute decompensation, often taking a long time to show their full long-term benefit.
So what's the mechanism of this seemingly counterintuitive yet profoundly beneficial effect in heart failure? How do they help long-term?
Their mechanism in heart failure is multifaceted and targets the chronic maladaptive responses. Firstly, they reduce the chronic deleterious adrenergic drive on the myocardium. By blocking the effects of excessive sympathetic activation and circulating catecholamines, they essentially shield the heart from continuous overstimulation and toxicity. This leads to positive left ventricular remodeling, helping to reverse some of the pathological thickening and dilation and improving overall ventricular geometry and function over time. By blocking beta-1 receptors, they reduce the chronic intracellular cyclic AMP and calcium overload within the myocytes, which directly protects the myocardium from catecholamine-induced damage and apoptosis.
Protect the heart muscle itself.
Yes. They also lower the threshold for life-threatening arrhythmias, offering crucial protection against ventricular tachycardia and fibrillation, which are common and fatal in heart failure patients. Carvedilol, in particular, also provides beneficial vasodilation through its alpha-1 blockade, further reducing afterload. Crucially, beta blockers reduce heart rate, which serves two key functions. It improves left ventricular end diastolic filling time, allowing the ventricle more time to fill and develop pressure with less congestion, thereby optimizing stroke volume. And it reduces myocardial oxygen demand, providing an anti-ischemic effect, which is particularly helpful in patients with underlying coronary artery disease. So, while they initially reduce contractility, their long-term benefits on remodeling, sympathetic overactivity, and rhythm outweigh this acute effect.
What are the common adverse effects of beta blockers, and are there any critical contraindications we need to be aware of, things students must remember?
Common adverse effects include bradycardia, slow heart rate, AV block, impaired conduction through the AV node, an initial transient loss of contractility, which is why slow titration is key, and peripheral vascular disease symptoms, such as cold extremities due to vasoconstriction in the digits. Patients may also experience a blunting of their maximal heart rate response, leading to exercise intolerance. CNS effects like vivid dreams and fatigue are reported, and a controversial link to depression exists. In the respiratory system, they can cause bronchoconstriction, which can exacerbate asthma and chronic obstructive pulmonary disease, COPD, by blocking beta-2 receptors in the airways, so they are generally avoided or used with extreme caution in these patients.
Careful with asthma COPD.
Very careful. A critical contraindication is uncontrolled type 1 diabetes mellitus, as beta blockers can mask the vital sympathetic warning signs of hypoglycemia, like tachycardia, tremors, and anxiety, leading to hypoglycemia unawareness and potentially severe unrecognized low blood sugar episodes.
Our last pharmacological agent is digoxin, a traditional heart medication whose role has significantly changed over time. What's its mechanism, and what's its current, more limited place in modern heart failure therapy? Seems like it used to be much more common.
Digoxin, an old but still relevant drug, exerts its primary mechanism by directly inhibiting the Na plus K plus ATPase pump on the cardiac cell membrane, as we discussed earlier, under contractility.
Right, blocking the sodium pump again.
Exactly. This leads to increased intracellular sodium, which in turn reduces the outward gradient for the Na plus Ca2 plus exchanger, causing increased calcium to remain in or enter the cell. This ultimately results in more calcium available for binding to troponin C and calmodulin, thereby increasing contractility. Additionally, digoxin has significant vagal effects, slowing AV nodal conduction. Historically, it was widely used as a positive inotrope for heart failure. However, major clinical trials, such as the landmark DIG trial, Digitalis Investigation Group trial, have definitively shown that when added to modern standard therapies like ACE inhibitors, beta blockers, and diuretics, digoxin offers no mortality benefit for heart failure patients.
No survival benefit.
Right. It does show a modest reduction in hospitalizations for heart failure, primarily by improving symptoms. A significant challenge with digoxin is its low therapeutic index, meaning the margin between therapeutic and toxic doses is very narrow, leading to a high risk of adverse effects, including dangerous arrhythmias.
Tricky to dose safely.
Very. Therefore, its current role in heart failure is much more limited and nuanced. It is mainly used for rate control in atrial fibrillation with heart failure, particularly when other agents like beta blockers are contraindicated or insufficient. Less frequently, it might be used for its modest inotropic effect in patients with severe heart failure and sinus rhythm, but only when other guideline-directed medical therapies are optimized and symptoms persist. It's truly a fading star used only for very specific indications now.
What an incredible journey through the intricate world of cardiac pump function, the devastating mechanisms of heart failure, and the sophisticated, often paradoxical ways we now manage it pharmacologically. It's truly amazing to see how fundamental physiology, complex pathology, and targeted pharmacology are so deeply intertwined, each informing the other.
Absolutely. The core message here, especially for you preparing for exams in clinic, is that heart failure involves a complex interplay of the initial cardiac insult and the subsequent activation of initially adaptive but ultimately profoundly maladaptive compensatory mechanisms. Effective management isn't just about bolstering the pump directly. It's crucially about interrupting these harmful neurohumoral responses and the process of pathological remodeling, often with drugs like RAAS inhibitors and beta blockers, while optimizing fluid balance with diuretics, all to achieve optimal cardiac output and improve patient outcomes and quality of life. Understanding these details, from the subtle cellular ion exchanges to the grand systemic compensatory loops and their precise pharmacological targets, is paramount. This raises an important question for you to consider as you digest all this. How might the precise timing of pharmacological interventions relative to the specific stage of heart failure and the activation of these compensatory mechanisms fundamentally alter a patient's long-term prognosis and profoundly impact their quality of life?
A powerful question to ponder as you continue your studies. We've certainly covered a lot of ground today, peeling back the layers of this fascinating and challenging topic. Thank you for joining us on this deep dive into the heart. Keep exploring, keep learning, and keep asking those critical questions that drive us to truly understand.